I'm Cristina Maniwan, and my presentation is about osteoporosis. To start, we have our typical patient presentation. A 70-year-old Caucasian woman visited her doctor for a monthly physical checkup. For the past year, she has been complaining of severe back pain, and she has also suffered a hip fracture, which required surgery. The doctor also observed that she has been slouching and lost 1 inch of her height. She experienced menarche when she was 18 years old, causing severe acne. Because of this, she was prescribed retinoids by a dermatologist. Osteoporosis is caused by the loss of bone mass. This may be because of low peak bone mass, which is the maximum bone mass in a lifetime, excessive bone resorption, where bone formation is not enough to compensate, decreased bone remodeling, where there is less bone formation, and changes in size and shape of bone due to excessive loss of calcium. Next, we have the background of osteoporosis, which is also known as porous bone. Porous means porous because in osteoporosis, there are many pores in the bone. An estimated of around 10 million Americans have osteoporosis. The prevalence of osteoporosis in 2010 was 10.3%, and more people suffer from osteoporosis in their 60s or 70s because this is an age-related disorder. 1 in 3 women over 50 years old experience osteoporosis, and the mortality rate of hip fractures, which is a complication, is around 15 to 20%. There are many risk factors for osteoporosis, and that includes genetics. Osteoporosis may be an inherited disorder, and this is more common in white women. We also have lifestyle and diet. So if someone is a smoker, consumes excessive amounts of alcohol, has low calcium and a vitamin D diet, he or she is at risk for osteoporosis, but more so women. Next is marrow disease, which is at the bone marrow. We also have drugs, and examples are corticosteroids, dilantin, heparin, retinoids. We also have hormonal and metabolic. So early menopause, late menarche, obesity, and acidosis are all risk factors. In illness and trauma, I have 2 examples. One is rheumatoid arthritis, which is an autoimmune disorder where there's an inflammation of the synovium accompanied by bone erosions in multiple joints. So here, the stimulation of osteoclasts brings about a specific type of cells which promotes osteoclastogenesis, meaning creating or production of osteoclasts. And osteoclasts are responsible for bone resorption, but we will connect this to the pathophysiology of osteoporosis in the next slide. But this is the main reason why there are bone erosions in rheumatoid arthritis. Second, we have hypocalciuria, which means too much calcium in the urine. So here there is an excessive loss of calcium, which may weaken bone density and increase the risk for fractures. So now we're at the pathophysiology of osteoporosis. Bone remodeling is a cycle of removing old bones and replacing them with new ones. This is a long process that may take even up to like 10 years. In bone remodeling, there is a process called bone resorption, which is the breaking down of old bone tissue through osteoclasts. And as mentioned, the bone undergoes a cycle of modeling and then remodeling. And in modeling, this is where bone formation and bone resorption occurs at different sites. And this is where a change in bone geometry is also observed. And remodeling is responsible for maintaining bone strength and integrity. There are 3 cells that are important in this cycle: bone-forming osteoblasts, bone-resorbing osteoclasts, and osteocytes. Osteocytes are the most abundant cell types. These are used to communicate between osteoblasts and osteoclasts in the cycle. So here's a picture of the 5 stages of bone remodeling. So these tiny little blue circles, these are osteoclasts, and these will take or remove a part of the old bone. So as you can see, there's that big gap. And the green little rectangles are the osteoblasts, and these will create new bone to cover that part. And so that's basically how the cycle works. And the amount of bone resorbed must always equal the amount of bone being formed to maintain bone homeostasis. Any disruption of this balance will lead to bone diseases such as osteoporosis. An example of that disruption is when resorption occurs more frequently than bone formation. This causes the bones to become brittle, weakening it over time. And so this may lead to fractures and may also change the shape of the bones. And so this is why the bone remodeling cycle is important because, again, it maintains the general bone homeostasis. Part of the pathophysiology is the mechanisms of osteoporosis. There were a lot, but I'll give only 2 examples. So here we have the accumulation of senescent cells, and these are cells that have a pathological role in age-related diseases. This can also affect tumor suppression and wound healing. And so this accumulation can lead to a senescence-associated circulatory phenotype, or SASP. And this is basically like a state where cells entering senescence are characterized by excessive production of pro-inflammatory cytokines, chemokines, and extracellular matrix-secreting proteins. And this can lead to the disruption of the bone remodeling cycle, which again causes osteoporosis. So we have our second mechanism. So here we have the gut microbiome and the short fatty acid chain. And these can cause the immune cells to not function properly, which may lead to like a disruption in the cycle, which may cause osteoporosis. For the symptoms, we have fractures, complications because of these fractures, and kyphosis. So fractures are characterized by a pain and change in bone density, and symptoms may not be observed until a fracture occurs. And often, complications arise because of these fractures. So I have 3 examples. I have pulmonary embolism, which is the blood clotting in the lungs. So one of the risk factors is being inactive for a long period of time. Also after surgery, since you're just bedridden, you can't really move. And if you have a broken bone, that's also a risk factor. For pneumonia, there is an increased risk when there is a fracture. Hemorrhage, since bones contain blood, when these bones break or they get fractured or they're broken, there's a possibility that blood loss may happen or hemorrhage. And we have kyphosis, which is the vertebral collapse. This is also called like a hunchback. So this is where an increased curvature of the spine, and as you can see in that picture, the upper part is really bent. And that can mean that the bone cannot support itself because it's too weak. And this may often cause like severe back pain. To diagnose osteoporosis, we use a standardized test. And so this is based on a person's bone mineral density and the average bone mineral density of a population. So we can use a T-score, the Z-score, or DXA measurements. So in the T-score, this is where the results of a person's BMD is compared to the average of a population. The difference between the population and the patient's result is calculated using a unit called standard deviation, or SD. When the standard deviation is between -1 and 1 or higher, your bone density is normal. If it's between -1 and -2.5, you have low bone mass and you're at risk for osteoporosis. If that's between -2.5 and -4, you have osteoporosis. We can also use the Z-score, and this is basically the same as the D-score. However, a population of similar age and gender is used. And so when a score of more than 2 SDs between a population, and that indicates a low bone density. We can also use the DXA measurements, and this was created by the World Health Organization, and this is a clinical tool used to diagnose osteoporosis and observe changes throughout or over time. And this is a method of BMD measurement. There are different types of treatments for osteoporosis. We have pharmacotherapy and surgical treatments. In pharmacotherapy, we have biphosphonate, which inhibits bone resorption. There are different types of biphosphonate. We have alendronate and rhizogenate, but they both have similar functions. They both increase the BMD and reduce the risk for fractures. We have also denosumab, which prevents the activation of osteoclasts. We also have raloxifene, which reduces vertebral fractures or the symptoms, and odonocatib, which is a cathepsin K inhibitor. So by affecting this enzyme produced by the osteoclast, the bone density is increased. So for the surgical treatments, we have vertebroplasty and kyphoplasty, which are basically just surgeries. And vertebroplasty, this is a surgery where a special cement is inserted into a fractured vertebra, and the goal of this is to elevate the pain and restore movements or the mobility of a person. Kyphoplasty is also quite similar to vertebroplasty because they both use a special cement and insert it into the fractured vertebra to treat the pain or elevate the pain and hopefully fix the problem. And that is it for my presentation. Thank you for listening.